clinical practice. Before the 1980s, left ventricular dysfunction was believed to be an irreversible process. The term hibernation myocardium was created after the perception that some patients had improved ejection fraction after coronary artery bypass graft surgery. After case study by Hamintula, we are able to explain the increase in ejection fraction after revascularizations. The hibernation is part of a cellular survival program. When there is a decrease in blood flow, there is a decrease in ATP and energy. Cardiac cells use 60% to systolic function, 15% to diastolic function, 5% to electric activity here, and 20% to cellular integrity. The heart intelligently does not use about 60% of the energy necessary to systolic function and concentrate the energy in other vital functions in hibernation situations. So, hibernation myocardium is the myocardium with a reduced contraction, has a protection factor, so that minimal energy is consumed to prevent apoptosis and cell death. Histological analysis of hibernating myocytes demonstrate a no contractile state with intact membrane and metabolism with small samples or evidence of apoptosis. Stunned myocardium is characterized by disproportionately long but fully reversible contractile dysfunction that follows brief episodes of myocardial ischemia when coronary blood flow is fully restored. Here, an example in the pink background is the blood flow here, the pink background, and the headline is the contraction. In the myocardial stunning, when the flow decreases, the contraction decrease together. Here, I can, here. There a moment here when the flow returns, but the contraction returns more slowly. Here. In B-ficure, we have short periods of hibernation with a decrease in contraction proportional to a decrease in follow. Here, myocardial hibernation. In C-ficure, a hibernation by repeat continuous moments of stun with minutes, okay? And here we have a chronic hibernation by months or years. And is a chronic situation here. Hibernation is a protective phenomenon that occurs in the presence of reduces blood flow. Stunning is not a protective phenomenon, but a manifestation of an injury where contractile reduction remains even after blood flow has been restored. Principles of viability: presence of a myocardial blood flow, cell membrane integrity, preserve metabolic activity. The myocardial blood flow. Tracers use it with a technetium, with a MIBI, and tetrophosphine. MIBI is not the best method to assessing viability, as viable regions with low blood flow can be misclassified as scarce. Nitrate can increase sensibility as it is a coronary vasodilator. Okay, here an example of nitrate. Cell membrane integrity can use thallium, and rubidium. Thallium is a potassium analog. Potassium is the main intracellular cation. It is absent in scar tissue. Here we have an example of a thallium 201. Here the sidewall is altered with signals of viability in redistribution image after the rest. PET analyze viability through the difference or mismatch between perfusion and metabolism image. To use the FDG, 18 FDG with glucoses. In the place where he had a low perfusion here, the glucose labeled fluor image show, and here A is perfusion and B is metabolism margin, shows even higher metabolism than the rest of other cells, other image here. And this is a case with a viability. A bright light arises where it seems to be deaf. Is the light. To summarize methodologies for viability detection: cell membrane integrity with a thallium 211, contractile reserve with a stress echo, mitochondrial integrity with MIBI, glucoses utilization with 18 FDG PET, and absence of myocytes with MRI. Most methods divide the myocardium in 17 segments, but there are only 3 main coronary arteries, one with a different color, red, yellow, and blue. Only 3 main coronaries. Therefore, it is necessary to analyze exactly which segments are being irrigated by each of the coronary arteries in each cases. Okay? If you round about these segments to 20, 70 to 20, which one will correspond to only 5% of myocardium, total myocardium, okay? Here, another picture to show the segments and the three main coronary. This is utilized in many methods, not for scintigraphy, né? Used in echo and other image methods of detection. Here, this patient has a history of infection in the inferior wall with a 10% of necrosis. Nevertheless, each main coronary irrigates more segments than just 10 of left ventricular. If we was not submit this patient to stress image and we have an estimating necrosis of 10% without viability, the doctor can read the expression, no viability, and they give up on revascularization. If the lesion is located in the coronary proximal portion, we have other areas at risk and can be areas with a lot of ischemia, like this, a lot of ischemia. This is rest, and this is the stress image with a lot of ischemia. Necrosis plus ischemia in this case. Areas of necrosis surrounded by areas of ischemia in the same topography are common finding on scintigraphies. Here is an example of a patient with an anterior wall infarction with a necrosis, like a 50% more in eps of a myocardium. However, other viable areas are irrigated by the left anterior descending coronary artery, such as the basal segments here, and the entire septal wall here. Septal wall is by the left main artery. The attending physician may consider not revascularization this artery since the report showed no viability in the rest of image. However, the territory of anterior descending coronary artery stands beyond of this, beyond of the eps. If we consider three territories in the left ventricular myocardium, the percentage of each main coronary artery will be about 33% of total. When the fibrotic area is restricted to the apex and the surrounding segments, it is important to analyze whether the coronary lesions are proximal or distal. If they are distal, clinical treatment is indicated. If they are proximal, there is a great tendency to perform invasive therapy due to the higher area of a myocardium at the risk. A stress test may aid in therapeutic decision. The STICH trial showed that the absence of viability was associated with no difference between drug therapy and revascularization. However, an analysis performed 10 years after that study showed that the ejection fraction increase was greater in patients with a viability. Here, I show to us. Here, patients with a viability and patients without a viability. Patients we do surgery and patients with only medical therapy. The two groups with the viability had improved in the ejection fractions. Viability is a signal of a good prognostic. The Revive study, is new study, showed no difference between clinical and percutaneous treatment. Stitch was a surgery study and the Revived is a percutaneous study in patients with a left ventricular dysfunction. In this case, all the patients with a viability too. Which did not show benefits, the Revive study, in percutaneous revascularization, even patients with a viability. But the criticism about this study is they only lasted 3.5 years, and the patients didn't have much angina. Does myocardial revascularization in patients without acute events really have no benefits? It's about ischemia trial too. So does myocardial revascularization in patients without acute events really have no benefits? Before opting to clinical treatment, it's necessary to think: would you allow for major surgery, no cardiac surgery, with anesthesia if your patient had a lot of coronary lesions and ischemia? The good doctor tries to act before things have happened. Some questions. So before applying Reviver or Stitch or ischemia trial, I recommend asking to your patients: will the patient need to undergo any procedure? Does the patient have a cancer? Does the patient practice high load sports? Does the patient accept to take several medications for angina? Or do you prefer put a stent anyway? Is important questions. Ischemic heart disease is very complex and can manifest in different functional and anatomical ways. Therefore, it's not always in medicine possible to create a general rule like today chronic patients only to do medical therapy. It's not possible to create this general rule. As René Descartes said, there are no easy methods to solve difficult problems. Thank you. This is my email to communication. Bye-bye.
Thank you so much, doctor. Thank you so much. Now we come into the conclusion. My heartfelt thanks to all the speakers, attendees who made this event a success with their eminence and presence. We hope to meet you all tomorrow for more exciting and thought-provoking research work by several